Greetings and welcome to this module on aminoglycosides. In this antibiotic series, we'll discuss about gentamicin, tobramycin, and amikacin. We'll discuss in detail about the mechanisms, indications, toxicity, and the dosing. After watching this video, you don't need to watch any other video on aminoglycosides to know more about it. There are use case in physician as well as in a critical care setup. If you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. Let's get started. So aminoglycosides are there for long years now. Again, it is they still matter today, even in this world of carbons and BLBLAs. Why? Because it is a very potent gram-negative. It is a rapid bactericidal killing. It is concentration-dependent killing, where beta-lactams, BLBLAs, carbapenems are time-dependent killing. These are concentration-dependent killing. So these can be used as carbapenem sparing agents, empiric treatment for MDR gram-negative organisms, and a single-dose cystitis therapy. So these are basically precision drugs. Benefit depends on correct use cases, not for every other organisms. So in this class are gentamicin. They are used as a traditional synergy dose. Nowadays, it's used as high dose gentamicin, used as a synergy with ampicillin or carbapenems or beta-lactams, penicillins, treatment for enterococcus and other organisms. Gentamicin has the lowest nephrotoxic potentials. It is mainly used for Pseudomonas. Amikacin has the best gram-negative organism coverage, ICU workhorse. So mechanism it binds to 30S ribosomal subunit, cause mRNA misreading and production of non-functional proteins. So it is a concentration dependent killing again. So most antibiotic effect is there. So it's peak concentration that kills the organism, not the MIC ratio, not the time. So once daily dosing exploits this advantage. Once daily dosing is enough. Never give this twice a daily or thrice daily because more nephrotoxic risk is there. So major contraindications are again myasthenia gravis, similar to macrolide antibiotic. Aminoglycosides also should not be given in patients with myasthenia gravis and other significant neuromuscular disorders. Related contraindications are pre-existing renal dysfunction, oliguria, anuria, recent aminoglycoside use in less than past 1 month, concurrent nephrotoxin usage, therapy for more than 7 days. In all these use cases, try to avoid aminoglycosides. These are relative contraindications. But one thing is generally safer, you can give that. So nephrotoxic spectrum, gentamicin is the most nephrotoxic, whereas tobramycin is safest. Amikacin is lying in between. It has the maximum gram-negative bacterial coverage as well as is one of the most intermediate in the nephrotoxic range. So tobramycin may reduce AKI risk compared to gentamicin. So ototoxicity is again very bad at this antibiotic. Okay, no, don't use in case of pre-existing hearing disease. Concurrent drugs such as don't use furosemide platinum-based chemotherapy with when you are using aminoglycosides. It is the dose and duration dependent the side effects. So gentamicin is vestibular toxic and amikacin is cochlear toxic. Hearing loss is there. Tobramycin is balanced and comparatively safer, but still it can cause short-term vestibular toxicity. So drug interactions are predominantly very minimal for aminoglycosides. So dynamic interactions are there. It has synergetic action, synergetic nephrotoxicity if you give it with along with vancomycin or other contrast, synergistic prototoxicity when given along with antibiotics, and differentiates non-neutralizing agents like neuromuscular blockades and cause severe neuromuscular dysfunction and myasthenia gravis exacerbation. So basically, again, the overview side effects are nephrotoxicity, ototoxicity, and neuromuscular blockage. These three things you must remember about immunoglycosis always. So neuromuscular junction mechanism is it decreases presynaptic acetylcholine release and it decreases postsynaptic sensitivity also. So both it acts in the presynaptic and the postsynaptic region to decrease the neuromuscular junction activity. It is worsened by hypercalcemia and hypomagnesemia again. General pointers, these are excellent non-negative killing organisms with a low Clostridium difficile infection and rare cause of allergy. So it's best suited for urinary tract infections, but it has a very poor penetration for the lungs and CNS. So never use it for pneumonia. Also, it again has a very narrow therapeutic index, so don't go for higher dosages. Just give the adequate dosage for that body weight. So main use scenarios or high utility scenarios are when there is multiple antibiotic allergies in these patients. These are almost and always non-allergic. You can use this. Carbapenem is sparing in urosepsis. These are again very rare use cases. Now, if carbapenem is not available, In case of cystitis, single IM dose could be enough and sufficient. In case of empiric gram-negative organism, in select cases, you can use aminoglycosides. So tobramycin is renal safer, less nephrotoxic than gentamicin, slightly better gram-negative coverage. The only problem with tobramycin is that it misses serratia and acinetobacter. Plus, amikacin is the big gun, also called the big gun. Best MDR coverage is there for amikacin. It is again, it can act against resistant Pseudomonas, also ESBL Klebsiella. Even gentamicin would be resistant, but it is sensitive to amikacin. So it is nowadays used as a empiric agent in the ICU for the maybe for the first or second dose. Only 2 doses, not more than that. So indications, monotherapy, it is nowadays limited because of advance of antibiotics. So it can be used as monotherapy, rarely in case of urinary tract infection with or without bacteremia. In case of tularemia and plague, it is a very effective antibiotic. So the double gram-negative coverage, there is no mortality benefit as far as RCTs are concerned. So it can be reasonably empirically only in case of IMDR risk and septic shock until sensitivities are back. Only these two indications are there nowadays. As a double antibiotic. Gram-negative coverage there. Again, we have discussed is highly gram-negative with the Enterobacteriaceae, E. coli, Klebsiella, Pseudomonas, and Acinetobacter. Resistant often co-travels with ESBL and KPC. So gram toxin, it acts only for a synergistic action, not as a monotherapy. Never as a monotherapy. For it can cover Streptococcus aureus, including MRSA as a adjunct or synergistic therapy. It can act against Coagulus negative Staphylococcus and Enterococcus species. Right. I again remember it is resistant against Staphylococcus saprophyticus. It is only effect against Staphylococcus aureus and Coagulus negative Streptococcus. So again, teaching strategy is high dose extended release is preferred. So it has a maximum peak concentration and minimum toxicity. So traditional multiple daily doses for renal failure and burns, you can give a single dose of IM therapy for status can also be given. These are dosing strategies. Again, there is one method called Hartford method where you will give large dose and allow a long time for the workload of the treatment. So it reduces the cortical accumulation in the kidneys. This can be given in case of when there is a renal dysfunction. You can go for a long dose and large dose and allow it to excrete through the urine before giving a longer dose. This is called Hartford method. It is not done in case of pregnancy when GFR is very less, that is almost 40, oliguria, anuria, cystic fibrosis, significant ascites, and burns more than 20%. This Hartford method cannot be used. Calculations based on the body weight and is more than 20% of ideal body weight, which is given. Adjust body weight, like this is the adjusted body weight calculation. Actual body weight calculation is just 0.6 into ideal body weight plus 0.4 into actual weight. This is the adjusted body weight. So maximum dose cap for gentamicin is 70 milligram. Amikacin is 700 milligram. GFR is more than 60 is you can go for 7 milligram per kg for 24 hours. Case of 30 to 60 again 7 milligram Q 36 hourly, and if GFR less than 40 go for traditional dosing. Therapeutic drug monitoring is done. Check mid-level at 6 to 14 hours. Plot on Hartford Nomogram. Trough should be less than 0.5 mcg per ml. Additional targets are achieved at trough level less than 1 milligram per liter. Efficacy for pneumonia at 7 to 8 milligram per liter. Gram-negative is at 6 to 8 and endocarditis at 3 to 4 milligram per liter. So pharmacology, it is very hydrophilic drug, low protein binding, renal elimination with almost no metabolism and half-life of only 2 to 3 hours. It penetrates kidney, urine, synovial fluid very well and very poor penetration into the lung, CNS and prostate. Final clinical summary used when the source is urinary and organism suspect to be MDR gram-negative organism. Use it only for a short as a shotgun therapy, maybe only 2 doses, not more than that. When you need carbapenem sparing, when the carbapenem is not available, you can go for aminoglycosides. And always avoid aminoglycosides when there is neuromuscular disease, poor renal reserve, and prolonged therapy anticipated. So basic scenario in a well established hospital or an ICU setup, you don't always even use an aminoglycoside, and in my 2 or 3 years of practice in a very tertiary center corporate hospital, I've never seen usage of aminoglycoside in the ISO setup except for acidotic in rare cases and antibiotics with synergism with ampicillin. So there is not much of use case of aminoglycosides these days with advent of other advanced antibiotics such as carbapenems like meropenem, imipenem, and the carbapenem sparing drugs, and even for an NDM variety of carbapenem resistance, you can go for ceftazidime with astronam, and there are also availability of polymyxins, colistins, and BLPLAs combinations such as piperacillin tazobactam. All these are very good drugs in the present scenarios with very less side effects compared to the aminoglycoside antibiotics. So hence they are almost equal. In case of practice, when you suspect a patient with cystitis and when they are not able to take IV antibiotics in case of not willing for admission or something, you can give a single dose of gentamicin IM injections as 80 to 100 milligram so that the one single dose will benefit them. So we learned a lot about amyloid antibiotic and its nuances and the clinical use cases in current era. If you like this video, do like the channel and subscribe. Thanks for watching. This is Medicine Beyond Horizons.